Hi, and welcome back to the Playground Talks podcast. My name is Temi Efriat. I'm your host, a mother of 3 kiddos, and a certified parent coach. And I'm on a mission to help you, mom and dad, to set boundaries with compassion. Today, we'll focus on one of the physical boundary, which is your child need to urinate and bowl. And it might sound easy, but truth is that many of my clients are struggling with potty training and bedwetting, and that's why I'm honored to have Dr. Steve Hodges, who is a leading authority on childhood toileting issue, to share his knowledge about that. So Dr. Hodges is a professor of pediatric urology at Wake Forest University School of Medicine, and he wrote 8 books. Today we'll specifically talk about his book, the M.O.P. Anthology, where he discussed bedwetting and accident aren't your kid's fault. And I'm so honored to have him, so let's get started. Hi, Dr. Hodges. Thank you so much for joining me.
Thank you very much for having me. I appreciate you taking time to talk about these topics.
I appreciate you coming as a leading authority on childhood toileting issues. And so before we even dive into the bedwetting issues, I want to start and ask, in your perspective, do you support child or parent-led potty training?
Yeah, so I'm a bigger fan of child-led to a point, obviously. Some kids would be fine to be in pull-ups till they're much older than, maybe appropriate for society. So I like after the age of about 3.5, you can kind of introduce it and kind of let them go at their own pace. So I guess I would say it's kind of a combination, right? Yeah, because I'm not totally hands-off. I don't let them stay in pull-ups forever. Once I think they have the ability to be potty trained, I'm totally cool with parents taking an active role in that.
So many times parents would say, oh, before my kid is going to preschool or, changes or have siblings, they would go, that's the good time for us to potty train them. So what would you say the signs that the kid is ready for potty training?
Really sets you up for potty training success, broadly speaking, until you're about, over 3. Now, of course, there are a lot of kids that can train younger and do fine, and there are kids that train later. But I feel like when you have a kid much younger than that, then you're having to put a lot more effort into it, guide them, control them. So you're really kind of, training them in combination with yourself. You're not really giving them much independence, even though we don't think independence is great in this area in general for a long time, because kids are still young, even at 3.5. But I feel like you're having to hover quite a bit, and you have more issues if you train when they're younger and they don't know that, it's important to go on time and not just hold it.
Mm-hmm. So, yeah, I agree with you. There is a fine line between the area where you can give independency, where are the things that it's basically the parent's responsibility to navigate the ship. So I totally get that when it comes to toileting, at the end of the day, it's the child needing to do the action. So what happens in the brain during this potty training process?
Yeah, I think, nature has designed this really well. It's a good system. It works in all animals, but people, I think, are a little bit too smart for their own good, and we overthink it. And the main issue in kids is that pooping is uncomfortable. I don't think any kid goes through childhood with totally pain-free and simple poops. They're always, going to be variation, and maybe they're too loose, usually too hard. So they develop this withholding behavior. Also, it takes a little bit of, I think, more mental effort for a kid to let a poop out than it does to let a pee out. So it becomes more of a issue where they're maybe, hiding in a corner or thinking about it or maybe fighting it too much. And so all that leads to child thinking, when I have to poop, I'm just going to hold it in. I'm going to squeeze my sphincter until the urge goes away, and then, problem solved. I'm done. And not thinking that this poop is piling up. So that simple behavior there over time will lead to buildup of poop in the colon, and then more painful poops, in the future. It snowballs, as you can see, then they start holding more. And then you get to a point where you've held so much that you lose the normal sensation in the brain. So maybe you need to pee, but you can't go in time because your bladder is overactive because of that pooping. And then the poop might fall out because you lose sensation to poop because you've backed it up so much. So just by a simple delaying pooping, a lot of kids can lead to a condition where they don't feel the normal urges anymore, and they start having accidents. And then parents that didn't notice they got backed up are very frustrated that, or confused as to why they're having accidents all of a sudden.
So what I'm sensing, you're saying there is a downside of introducing the potty toileting process early on, where it can lead to those negative effects that you just mentioned of holding it too much and just losing the intuition on when do I really want to go potty. So is there any difference between potty training in terms of urinating night and day?
So I don't consider night training to be actual separate thing to do. I think, or I know that if you toilet train them and the bladder capacity is adequate, then they should be dry at night while they're sleeping. Unless, we have some cause of bladder overactivity, which is typically in this age group, rectal dilation due to withheld poop. There can be other factors, like if some kids can't get out of their bed or too scared or they're in pull-ups, but those are all conditions where they're actually peeing while awake. But if you're having a bladder emptying while unconscious at an age where the child is potty trained, then that's typically due to constipation.
So once the child is potty trained, if we see bedtime accident, that means that there is a medical issue.
Yeah, it's not a severe one, but one you can definitely treat. For example, my children, one of them did wet the bed, so I knew that wasn't right. I gave her some Miralax, got her cleaned out, and it stopped pretty soon. So I don't want to make it seem that easy because it's harder for different people, but I definitely addressed it and didn't just wait for it to outgrow it like a lot of the recommendations nowadays are.
So at what age would you say that bedwetting should stop being normal?
Yeah, that's a tough question because I don't want to be out here, expecting too much of kids or making parents do too much. I think if you have a child that wets the bed at any age, you should really make sure they're pooping well and probably add some type of laxative so that they're more regular, get more poop out. Dr. O'Regan, who famously did the research that our work is based on, treated his own son at 4 years of age, which is pretty young for most doctors. The general consensus is 5 years. I don't mind waiting to 5 to treat them if parents have a lot on their plate, but you can definitely treat it younger, and I don't believe in just ignoring it. Like if you have a child that's wetting the bed, do something to get them pooping better. And then if they're still wetting the bed at whatever age you want to treat it, then you can be aggressive. But I would hate to have a child that was potty trained at 3, wetting the bed, and just do nothing until they're 5, because they're probably going to get more and more backed up and may have more issues.
Got it. I want to dive into describing your treatment program, the M.O.P, and what does M.O.P means and why do you find it more effective than other approaches?
Yeah, perfect. So it's a good segue because we were just talking about Dr. O'Regan, whose research we based our work on. And so M.O.P stands for the Modified O'Regan Protocol. So Dr. O'Regan was the first to discover this association between rectal dilation, when kids put off pooping, and bladder overactivity, which is a bladder squeezing when you don't want it to. And he developed a protocol where he used a daily enema, which sounds aggressive, but it was very effective, to empty the rectum in these kids that had gotten backed up. And it makes really good sense because he's treating the cause right at the source, and he has excellent success rates early on. I was like anybody else. I was a little bit afraid to use enemas, but I oral laxatives and found out that enemas were more effective. And so we do have a protocol based on daily enema use, much like Dr. O'Regan. I think at this point we've seen more patients than he ever saw, so that's why we've had to modify it a bit for the more severe cases. Also, he only treated bedwetting. We treat daytime wetting, poop accidents, all the same. And the other causes that get kind of attributed to bedwetting are almost like flat earth theories, not to make fun of anyone, but they seem like they would be the cause, right? Because sure, the earth seems flat, but it's not. Sure, these kids seem very tired, they're hard to wake up. Sure, they seem like they're peeing a lot, and that all has ancillary roles in whether or not the bladder is going to squeeze, but they're not the root cause. So you can look at it like a pyramid. The base of the pyramid is the fecal retention or constipation, and then on top of that, you can modify their sleep or modify their fluid intake to maybe get them drier faster. But until you fix the root cause, you won't have a good lasting cure.
So when someone, let's say my child is 5 and he's still bedwetting, what would you recommend as a first step for the parents?
Yeah, I think if they kind of read our resources and kind of buy into it and it makes sense to them, then I would just start treating it. You can start simply with something like an oral laxative, or you can be more aggressive and use the enemas like our protocol is, which are going to be faster. Honestly, most parents come in and they're very nice and they want to help their kids, but they're like, I appreciate your input, doctor, but my child poops normally. I don't think that's the problem here. What if it's something else? I go, why don't we start with an x-ray? And we get the x-ray and we see they're really backed up. So I think if the parents are concerned that maybe this isn't the issue, get an x-ray, have it read by someone that knows what they're looking at, and I promise you it'll show the backed up poop, and then you can start the protocol. And a 5-year-old would be a great age to start treating, get them emptier, and you'll see slow progress. If you're having flooding the bed multiple times a night, you'll see that decrease to less than multiple times, maybe one time a night. Later at night, less volume, and eventually you'll see them dry. And it's definitely very satisfying when you see them get better with these protocols.
So what really happens there? What's the source of it? Why is it causing just during the night to happen?
Okay, yeah, good point. So the nerves that go from the bladder to the spinal cord to tell the brain, I'm getting full, or I feel full, or I need to squeeze, or whatever, all go around the rectum. And so in most kids, as you stretch the rectum out with poop, you get increasing amounts of bladder overactivity. So low level bladder activity, it makes sense if you think about it, is most likely to cause accidents at a time where you can't stop the accidents, which is when you're unconscious. So that's why bedwetting is so common and seems so prevalent in these kids, because it's the time where the kids are most likely to wet. Now, if you keep stretching the rectum, the bladder overactivity gets worse, and it'll seep into the daytime, and you'll start seeing kids peeing too frequently or too urgently. And parents are like, oh, they wait to the last minute to go pee, when in reality, they're not getting much of a warning. And then you'll see them not be able to get to the bathroom in time, start having day accidents, culminating in kids that pee on themselves while awake and don't even know they had an accident. That's severe cases. And then if you get more backed up, you can even have kids having poop accidents, which we would call encopresis, where the poop falls out of the rectum because they're so full of it that they don't even sense it anymore, and it just falls out into their underwear, and usually the parents notice it from the odor. And so that's why it can extend from night wetting, day wetting, all the way up to poop accidents. And interestingly, as we treat it, to stick with that logic, those problems get better in reverse order. So the poop accidents get better first, the daytime wetting second, and then the bedwetting.
So there is something that came up to my mind. If I see a kid that is, while laughing loudly or crying, also is urinating, is this also a sign of a medical issue with the constipation?
So that's a little complicated. So there's a specific kind of incontinence called giggle incontinence, which happens in girls, mostly, sometimes boys, where you only wet with laughing and you literally empty the bladder. And that's mediated by the brain. It's a strange developmental condition that is treated with Ritalin, honestly, or ADHD medicines. And so if you just have that problem, you treat it with Ritalin. If you have a child that has what sounds like old lady stress incontinence, where they're like, when I run, I leak, or when I play, I leak, but it's small leaks, like you would see maybe in an older woman, obviously these young girls are healthy and their anatomy is normal, so that's almost always a result of vaginal voiding. It can be complicated, but sometimes little girls will pee with their legs together. They'll pee into the vagina and they'll store quite a bit of urine in there, and then it falls out later when they're more active or more upright. So sometimes it's not your typical accident like we're describing. It might be different causes.
Okay, I get that now. Thank you. So are you the only one who offered that kind of M.O.P, of this treatment, or a parent could reach his, family doctor and they will know what to do with it?
So yeah, we've been doing this for a while, and we have a lot of folks around the country that are on board with our protocol, and we have some links to that on our website, which is www.bedwettingandaccidents.com. The primary kind of ambassadors for our program are the physical therapists, which a lot of time are treating these cases, and so we definitely have some MOP-friendly doctors and providers and therapists on our website. But I do want to warn parents, sometimes, you'll run into someone that's never heard of it and doing more of the traditional therapy, and might look at you kind of funny if you say you're doing enemas on your child. So I do encourage parents to be advocates for the children and try to get them treated. And, if the doctor offers another reasonable alternative and that's able to help your child, I'm all for it. But if you see another doctor and they recommend things that aren't helping, then I would definitely look at our resources. And a lot of it, honestly, you could do on your own. We have a lot of guides on the website and the books that can kind of talk you through it and hold your hand as you get them through the process. We have some online resources as well.
And we will attach them to the show notes, so everyone who wants can hop in and grab your book and your free download that you provided us. So I highly recommend for parents to go and do that. So how much time does it take for parents to see that the treatment is actually working?
Yeah, that can vary. And I'm obviously really happy when kids get better right away. Dr. Regan had a very high success rate for bedwetting alone in the first month of his enema protocol. And so if you have bedwetting alone, which would be a less severe problem, you can see success in the first month. And you want to look for several signs of success too, is to make sure you're making progress and not miss that. For example, if you came to see me with bedwetting, but the child also had a lot of frequency and urgency during the day, even though that maybe didn't bother you as much, that would get better first. So if you're treating just bedwetting, you're still wet at the end of the first month. But if you think about it, okay, now my child's not running to the bathroom at the last minute, then that's progress. Anytime you do the protocol for 4 weeks and you see no progress, then we do recommend we try to change things up or maybe get an x-ray to see where we are.
Can you get a little bit more in detail around the protocol itself?
So basically, our goal is to artificially empty the rectum as often as possible, as safely as possible, to get the rectum empty and let it shrink back down to normal size so the children can start pooping on time again and help the bladder function normally. And so Dr. O'Regan's protocol started off as just an enema once a day. And that was the kind of the basic O'Regan protocol. And he would have it for 1 month, and then he would taper over 2 months. We modified that, but at first by saying, okay, if you're not done at the first month, keep doing it. Don't stop it obviously at 1 month. And then we said, well, maybe we're not getting as empty as we can. Everybody poops once a day. Maybe we should add some oral laxatives into it. So basic M.O.P had some oral laxative in combination with the enema, hoping you might get more than one poop a day. Not every kid responded well to the oral laxative, so we added some X-Lax. We called that M.O.P X. Then we added some different types of enemas. We did M.O.P Plus, and most recently we've developed multi-M.O.P, which is, okay, we want these kids to poop as often as we can. We've found some enemas that are safe to use more than once a day, sometimes even up to 3 times a day, and those have been very helpful because the more you can get a bowel movement, because remember, not any one of these given enemas is going to empty you out completely. You kind of got to chip away at it. So the more we can do that, the faster they'll get better.
And for how long would you recommend to keep using the protocol? Like once no bedwetting, that's it, we're done? Or do we need to keep maintaining the process?
Great question. Depending on which protocol you use, there's different tapering. We definitely don't go cold turkey. So let's say traditional M.O.P, once you're dry, then you do a month of every other night enema instead of every day, and then you do a month of twice a week enema. And that's straight from Dr. O'Regan's work. If you're doing multiple enemas a day to get them dry, then we taper down from 3 to 2 to 1, and then off. So yeah, there's a lot of different ways that in general, and these were all basically just kind of adapted to what works for the kids. The main point is you don't want to stop right away. We have some parents of children that are significant withholders. They just don't want to go to the bathroom on their own, and they'll have to taper a lot more slowly just to keep their kids honest, because if they don't taper slowly, it'll recur. And sometimes we'll add in some stimulant laxatives like X-Lax either during the treatment phase or during the taper phase to make sure that, okay, now we're getting off the enemas. How can we keep this child pooping as often as he was before, or as effectively as he was before? And we have a lot of different protocols to kind of make sure that happens.
I know that many times there's this say the kid outgrow a bit. So what's your take around that?
About outgrowing bedwetting?
Yes.
Yes, everyone definitely outgrows these issues eventually, assuming they're the problem we're talking about, because this kind of pediatric pattern of voiding goes away. But the problem is no one knows when that will happen. It's about 15% a year, starting at the age of 5 is what they teach us. But we see lots of kids that are 12, 13, 14, 15, 16, 17 going to college, still wetting. So that's why we're not big fans of wait and see approach. It is possible, and if you have very minor problems, then maybe just keeping them honest with pooping is all you need to do. But most kids, it's best to treat them aggressively, because the sooner you can get this problem taken care of, the better their quality of life will be, and their bowel health, and their sleep, and so forth.
Got it. So I think I got the understanding of kids should be leading the process at the age of 3. You would see some signs that says that he's ready to start the process by himself. But then if by age 5, for sure, you still see some issues and bedwetting, that's a good sign for parents to start treating the bedwetting. Am I right?
Yeah, and again, like I did with my own kids, if they were wetting and you saw it, you should just reassess, like, how are they pooping, and you may not want to do full-on M.O.P for a 3-year-old, but you could add some Miralax or magnesium just to get them pooping better, and you may not have to do anything later because that will resolve the issue for you when it's early on. We see a lot of kids where they'll potty train and they're fine, and then the accents show up 3 to 6 months later. And so you can see for yourself what happened. The kid was pooping fine, then they got potty trained, and they decided to hold, and the problems developed later. And so parents are often confused as to why they showed up, but according to our protocol, it makes perfect sense, right?
Mm-hmm. So if you could get into the red flags for parents to go ahead and grab your book and get the protocol done, this will be great.
Yeah, I think my message would be not to ignore accents in kids, right? If a child's having accents, even if they're recently potty trained, if they're peeing on themselves, pooping on themselves, it's not a phase, it's not a power struggle. I promise you they would go to the bathroom if they could, and I would just aggressively kind of get in there and you could do a workup. There are rare conditions that aren't related to what we're talking about, right? So it's good to address the incontinence period to make sure they don't have a spinal cord disorder that was missed or some kind of anatomic problem. Just have the doctor look at them. Once all the health causes have been ruled out and they're physiologically normal, so to speak, then you can just jump on our protocol and help your child feel better, be more confident, and be able to control their bowel and bladder sooner, which I think it makes sense. If you wait a long time and this dilation lasts a long time, it's going to be much harder to kind of take care of it at another date.
And how much time would the potty training itself should take?
Oh, that's a good thing. That's a good point. So when they're ready, it should be pretty quick. Now, what I mean by that is the peeing experience. Peeing on the potty and controlling that is very simple and very easy when they're ready. So if you have a 3.5-year-old kid that has been pooping fine, no backup, and you put the potty out there, they're going to feel it. They can sit on it and go and be fine. And they can poop on the potty as well, too. The issue is some kids, the downside, so to speak, of training when they're a little older is they can develop habits. And one habit is I like to poop standing up, or I like to poop in my pull-up. And so I'd rather have a kid pooping in the pull-up than getting backed up. But once you have them peeing on the potty, if they're refusing to poop on the potty, which is pretty common, we have some techniques to get them to do that. And as long as they're getting empty, we'll get them there. Don't worry about it. It's not that hard to kind of get a kid that's not backed up to poop where you want them to. It's much harder to get a kid that's backed up, unbacked up, if they're having accidents.
Mm-hmm. I get that. Thank you so much. Towards the end, I want to ask you if there is anything else you would like to add to the discussion.
Yeah, I think that just to kind of echo what we've already said is that if kids are having accidents, I know it's frustrating for parents, or if they're peeing too urgently, every time they got to go to the bathroom, they have to go there the last minute, or they're peeing too frequently. Every time you try to get in the car, they need to pee, or during dinner, they're peeing 2 or 3 times. It's very frustrating to parents. Just remember, it's not their fault. It's a process that can happen to certain kids, and it's a little unfair because it doesn't happen to all kids. You have to have the right kind of genes and makeup for it to happen. And so just use it as a sign that there's something going on in their body, and you can treat it, and then you can help them get through this instead of just, because I know it's frustrating if there's wet sheets, if there's disrupted dinners because the kids have to go to the bathroom, parents can get frustrated. But let's focus that frustration on treating them as opposed to getting angry and punishing the kids, because it's definitely not their fault.
I get that. I also get that it's not the parent fault that it's happening, but it is the parent responsibility to recognize what's happening and to treat the toileting and the bedwetting issue. So thank you so much for your time. And we will add all the link. And I invite our listeners to approach you once they listen to this and realize that they might want to have a deeper dive into the subject. So thank you so much, Dr. Hodges.
Oh, yeah. Thank you. Yeah, thanks for having me. Yeah, we're happy to help anyone. We're available online.
Well, I hope they will use your knowledge and expertise around that. Have a good day. Bye-bye.
Thank you. Thank you so much. Thank you.